Sitting here with Q Willy. We tried Riverside and it failed, so we're on Zoom. Yeah, man. Tell everyone who you are.
Yeah, for sure. So name's Q. Yep, just like the letter. Are we doing this whole thing again?
Yeah, let's do it.
All right, absolutely. So, been a physical therapist for about 5 years now. Started with strength and conditioning at the University of North Carolina. I had done a lot of S&C before that, just like on the side. I was really interested in it and pursued a master's in exercise physiology while I was at UNC. I was with men's and women's basketball on the strength and conditioning side, and then I was fortunate enough during the master's program to share desk space with Greg Knuckles. Greg is just a fantastic person in the training and knowledge space when it comes to science communication around everything in the training space, particularly starting with powerlifting, but he's kind of ventured off into a lot of other areas now. And then Eric Trexler was also there, who's now at Duke in Herman Pontzer's lab. Herman Pontzer is the kind of foremost leading expert on metabolism and metabolic adaptations with aging. So both very, very smart individuals, and they introduced me to another individual, Derek Miles, who is the head strength and conditioning, or the yeah, I guess he's kind of head S&C and pain and rehab person for barbell medicine. And so between all of them, as well as the head strength coach for the UNC men's basketball team, they just kind of convinced me that going to PT school would be a good move if I wanted to have a little bit better seat at the table when it came to contributing to an S&C model and being able to communicate with healthcare professionals. It just, Jonas, the head strength coach, said, it's great that you have a master's, but if you got some kind of a medical degree, you would probably be able to bridge that gap a little bit better than what's being done. And I know that term kind of gets I don't know, poo-pooed now, the bridge the gap term, which I understand completely. So just using his words at the time. And did that, hopefully to seek out some brighter pastures than what was S&C at the time in terms of pay, only to find that I still do S&C and still get paid about the same. So, it was worth it though. Learned a lot along the way, had a lot of great mentorships, in PT school, you have to do a lot of different rotations. And so, got to see populations that I just would never have seen otherwise, like working with cerebral palsy, children, and then working with, a lot of, aged adults in a skilled nursing facility, a lot of like pre and post cancer treatment related stuff that happened there, and then worked at a VA. So just seeing like 55 and up males predominantly, with shrapnel in their shoulder, and that's why their shoulder hurt. Is really pretty fascinating and fun. Seeing a lot of really interesting cases during that time, onto a little bit more outpatient orthopedic and working with athletes a little bit more, and most recently working with football athletes at the University of North Carolina and barbell medicine and doing my own online stuff. So I see a myriad of different folks now.
So you were a strength coach with at North Carolina with basketball first.
Yeah, so I did more of like a GA type thing with University of North Carolina men's basketball and women's basketball. I played lacrosse at the University of North Carolina, so I also was friends with a lot of the folks on the Olympic training side. So I kind of would help out with them, like soccer, baseball, wrestling, volleyball, and would just dabble in those, but dedicate as much time as I could to S&C while also earning a master's in exercise physiology.
Mm. So they influenced you to do physical therapy. Was that the big influence, or were you kind of looking at strength and conditioning as like you wanted more?
Yeah, it's a good question. I really enjoyed strength and conditioning. I think ever since I was young, I was just really into physical culture in general. Um, and I think anything that related to improving performance or had something to do with training had just always interested me. I pursued a master's because it seemed like the most logical next step into writing textbooks. And I think during undergrad, I was reading textbooks and thinking to myself, well, someone is behind all these words. Like they didn't just appear on a page, and there's somebody who's having to go out and figure this out and like know these things. And I thought that was really intriguing. And that's why I pursued a master's and was thinking about pursuing a PhD and doing more academia. After a short period of time in the academic world, I just realized that I didn't like being behind a computer screen reading papers for the entirety of my interaction with the human world, and I needed something a little bit more practical. And I found that just being around the athletic environment as being an athlete myself was really fun. It was something that I felt really uniquely challenged by and fulfilled by. So I thought strength and conditioning was going to be the move. And at the time, when everyone I think goes through this evolution at some point, in their career, if you're interested in strength and conditioning or PT in general, is that you'll go through and you get your feet wet and you start getting exposed to a lot of really interesting ideas, ideas that maybe you'd never heard before. And then you get exposed to maybe some kind of a guru or expert or somebody that has a medical degree, and the way that maybe they appear to see and look at the human body and the way things move, it just seems like this whole another echelon above. And I think you just get really entranced and entangled in this idea that, like, oh, if I could just learn everything and know everything and see biomechanics the way they see it, if I could just find a quote unquote root cause and identify all these things, then me too, I could be a really smart person and fix people. And then, you know, fast forward multiple years and you realize that a lot of that's a load of shit. And, just because you can look at a body a little bit differently or take a lot of different metrics doesn't mean you're any closer to actually landing on what causes change in pain and what causes change in people, and that it's a lot more nuanced and complicated than just finding a quote unquote root cause, and that those things probably are a little bit further out of reach than we'd like to admit most times in clinical practice. And so, now I take a lot more nuanced and little step back approach, and that's why I've kind of landed more again back in the strength and conditioning and promoting overall self-efficacy and health and wellness, across a lifespan versus like trying to just fix the temporary pain or create a narrative where people feel like, oh, if I just moved in this certain way using this very specific paradigm, then I would be out of pain, and unless I do that, I won't be, and that's just not very well supported by the research. So I've leaned a different direction.
Mhm. Were you the black sheep in physical therapy school?
Yeah. Oh, yeah. In school, it was funny because I had like more experience as a professional. Because I didn't. A lot of PT students will go straight from their undergrad right into PT school, and so I had like professional experience outside of PT school. I was, a high level athlete, so I came in with a lot more confidence and just ability to speak, and so I was made class president, and it yeah, it kind of worked against the PT school to the students elected me, but I don't think the PT school really wanted that, because I found myself in the quote unquote like principal's office a lot, because I challenged a lot of beliefs. Uh, you know, for better or worse, I mean, being fresh out of a master's program in exercise physiology, I came in fresh with a lot of exercise physiology knowledge. And a lot of the initial year of your didactic training in physical therapy school is covering a lot of physiology, and a lot of exercise science related topics. And they were taught pretty poorly. And I could expose how poorly they were being taught. And I don't think that they enjoyed that very much. And I tried to be respectful and ask good questions, but they just didn't want to be questioned. They just wanted to we just want you to regurgitate what it is that we know, and I was not willing to do that. And anyways, here we are.
What were some of those things that you were challenging?
um yeah, reflecting back, I think a lot of it had to do, one of the first times I remember really like putting myself out there was like they were talking about muscle fiber typing, and like there was these like very distinct categories, and then even like hypertrophy research that like everything that you do in hypertrophy training or in strength and conditioning in general for the first like 6 to 8 weeks is 100% neurological adaptations, and there's not physiological adaptations that happen. And it's like, no, like probably not, because they're probably happening all along the way. We just don't have sensitive enough instruments to measure those like meticulously small things that are happening, because that would be like kind of ridiculous. Like that would go against a lot of other physiological properties and purposes and other like things that we know, mechanisms that happen in the human body, where it's not like you just hit this magical tipping point after 6 or 8 weeks and then your body decides to adapt. Like it's probably happening all along the way. And then even listening to the fiber typing related stuff, it's like, no, these are probably more of like a spectrum of change. We actually see that people that are more detrained tend to be a lot more hybridized in nature, where their muscle fibers kind of aren't really looking like one or the other. They're kind of waiting to be told, versus like I think a lot of the messaging I was getting was like, oh, if you have like an MMA fighter, they have very hybridized cells, muscle cells, because they have a hybridized form of training. And it's like, raise my hand, like, no, that's not how that works. It's actually the opposite of what you just said. And here's why. And this is why it makes sense. But it was just met with a lot of resistance. So, yeah.
Yeah, that reminds me of because that was taught, yeah, for me, undergrad and masters, the whole like initial is neural adaptation, and then like the hypertrophy is going to come later. Um, they had it in the tendon world too, tendon with tendon pain, because I want to talk. We haven't got the tendons yet, but of the initial pain decreases were suspected to be like neural adaptations, and then later would be like muscular changes, and then was like finally you're getting tendon structural adaptations. How are you looking at that? You're thinking like you're probably getting an impact like all the time with all those.
Yeah, I think so. What's funny about that specific outline that you just gave? That probably is a lot more of how it happens if you follow the typical treatment parameters that is often followed by like old school, outdated PT. Like, yeah, it does follow that a lot of the first 6 weeks are probably neurological adaptations because all you're doing is like feel good modalities and you're not challenging the tendon at all and you're resting. So, like, yeah, a lot of like things probably are just a little bit more of like nervous system calm down and not doing our, you're just not poking the bear and running behind the tree to hide as often. So like, yeah, probably you're going to feel better. That does not mean that you're anywhere close to being prepared to what you need to do, but it's probably going to feel better. And then what do we do next? Like, well, in typical PT, they do a lot of like BFR. They do a lot of like pretty low load resistance exercises. So yeah, I would expect that you're probably going to see muscular adaptations in those types of training modalities versus tendon adaptations. And then what do we end up doing? Well, eventually the person gets strong enough or comfortable enough that they can push harder, or the PT stops restraining them as much and says, "Oh, I think you're acceptable for load now." And now that we're putting real load on them, now we do get tendon adaptation. So it was all happening all the time, but that very outline that you gave is probably more of how it happens when you follow a poor treatment modality or poor treatment model. And I think that's funny that like we think like we're taught that that's how tendons adapt, and it's like, well, maybe that's just how they adapt because that's the really crappy way of treating them.
Yeah, yeah. Um, okay, so I went through my jumpers knee. I went through a few physical therapists in rehab, and it just didn't pan out. Like it wasn't good. Um, and I've talked to so many other physical therapists, physical therapist friends, and I'm always curious the knowledge that you gained in physical therapy school to work with someone like for me who was 20 years old with jumpers knee, wanted to play basketball, couldn't play, couldn't jump. Was there that education, did it prepare you to work with someone like that who has tendon pain and they're a high level athlete? Or not, I wasn't a high level athlete, but I wanted to jump 40 inches or whatever, you know?
Yeah, for sure. No, physical therapy school does not do that, and I think initially I was really aggressive with that and really angry and upset that like physical therapy school is so underwhelming in that. And I think more recently, talking with like educators, I've had to bite my tongue a little bit more often because if you think about like PT school, there's a lot of people who are going to work with, like I mentioned, the cerebral palsy children. They're going to be working with only traumatic brain injury. They're only going to be working with like maybe home health situation with geriatric patients and just trying to help them like get on and off the toilet and go about like just normal household stuff or even like hospice related care where it's like we're just trying to preserve like the last little bit of function and help with mobility and ambulation or help family members help their loved ones get around. So like and then you also have just like purely neurological PTs. You have people who my point is that there's a wide breadth of like areas that you can end up working in PT. And so I think it's unfair to criticize all of PT school for being so lackluster and poor in its ability to help with athletes when PT school is also trying to cover like the painting in broad strokes. And I think where we drop the ball in education is that we've created a curriculum that's supposed to like crank PTs through in 2.5 to 3 years, painting in broad strokes, and then expect that that education is going to prepare you to work with very niche specific people. I think there probably needs to be a little bit more vetting process and like residency or rotation process that's baked into the mix of like what is it that you really want to work with. Instead of becoming too much of a generalist, which is required to pass your board exams, there probably should be a little bit of a next step of like, especially for students like I mentioned who came straight from undergrad into PT school that don't really know exactly what they want to do, but everybody's like, oh, sports PT because it looks really sexy. I think that they probably do need to go actually be in a strength and conditioning environment for a while. Like they need to coach on the floor with real athletes. They need to see like the performance metrics, they need to be mentored by people who are in a strength and conditioning space, or at least PTs that really know about it, if that's what they're going to do. The same way that somebody who's going to go work with traumatic brain injury patients needs to probably shadow and work with people that know a lot about traumatic brain injury or spinal cord or post-stroke related patients. Like there's a lot of different regions and areas where you could go. And so, yeah, while I say that PT school really dropped the ball in terms of like helping someone with tendon pain get back to jumping, I also have to recognize that they're painting in broad strokes, and it's not fair to criticize them under that one area of expertise that I happen to just be very interested in, if that makes sense.
Yeah. What was your what was your experience like being an athlete, college in terms of strength conditioning, athletic training? Was it good?
Yeah, you know what? It wasn't always good, but I would say in reflection, a lot of it was actually quite good. I think where I initially started was we had uh, more of the football S&C type stuff applied to lacrosse, which really wasn't too bad. I think that the unfortunate part was that lacrosse was always kind of like the scrubs compared to like the football team got a lot of the resources, and that we were just kind of like the pain in the ass team that they had to coach on the side. And so it definitely felt like that at times. And it was just like kind of slapped together program, and whatever you lifted was whatever you lifted, and so there's probably a little bit lackluster on how good the coaching one-on-one was. But I think overall, like the exposure, the programming really wasn't too bad. I would say where in lacrosse specifically was still lacking, even at the University of North Carolina. And don't get me wrong, I mean, I loved my coaches at the University of North Carolina. I thought they were very good. But there is, when it comes to training, still very much an old school mentality of like, let's break open the box of eggs and throw them against the wall and see who cracks kind of feeling. And like this is all mental toughness training. So it was like, you would just start practice with like a mile run, and it was just all out around the field in your cleats with like half your gear on, and you would go straight from a mile run, and it was like required that you finish in at least under 6 minutes, and you went with 30-second rest, throw on your gear, and you're straight into like a full field passing drill, just about to puke. And it was just like that was every Monday throughout the entire season. And like our conditioning was, we used to joke that we don't play lacrosse, we play lacrosse country, because we just ran so much. And so like that side of things was challenging, but gritty, got through it.
Yeah. Were there for you? Were there injuries you had experienced and got through, or did you stay pretty healthy?
I was pretty fortunate. However, I think from a very young age, even before I knew what I knew now, I really felt that a lot of the treatment, a lot of the conversations I would have with physicians, a lot of the narratives that were being passed by the athletic trainers, even sometimes the strength coaches, I felt was just totally bullshit. And like really basic stuff. Like I learned very early, as maybe a lot of other young athletes do, that like static stretching maybe wasn't the most effective thing to do prior to engaging in like high velocity activity. And it was just kind of this weird thing that like unanimously every single team, we all static stretched before we played every practice or game. And it was like, why do we do this? Because I learned from like very 101 strength and conditioning class that like that's not maybe the most ideal thing. And it was like, that's weird because that's all we do. And so I think there was like instantly like a lot of skepticism in the practice of what we did. And then yeah, I guess when I dealt with injuries, um and it was just like scraping or cupping or dry needling or massage. I didn't feel like any of that stuff did anything. And there was like a huge lack of like, I'm having this problem. You're telling me that this thing will feel good, but I was like, but what do I do tomorrow? Like, do I just play? Cause like you did this thing, it's the same. Like nothing changed. Like it hasn't adapted. Like I need a plan. And it was like, nobody could give me any kind of direction on like, what is it that I'm actually supposed to do other than just come to you when I have pain, and you're just supposed to like put a band-aid on my boo-boo and like pat me on the ass and keep going. And it was kind of like I always felt like there was a huge disconnect in like the conversations, the communication. And then if I asked why or like what was going on, no one could really tell me. And I would have even appreciated if they just said like, oh, we're not really sure what happens mechanistically with these things. We're not really sure why pain happens in this area for this reason, but here's some things we do know, and da 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 da. But instead it was just like either a very pathoanatomical excuse where in the back of my mind I was like, there's no way that's what's happening. Like my tibia is not rotated 3 degrees to the right, and that's why this pain is happening. But you're telling me it is, and this already sounds really suspicious. So I kind of knew early. I dealt with like Achilles tendinopathy, shoulder stuff, being a lacrosse player, a lot of like wrist and hand related stuff. Knees were pretty good for the most part. Had some like hamstring related stuff here and there, but honestly, like I fared pretty well. A lot of lacrosse guys end up with a lot of, back related stuff or hip labral related stuff because of rotation, and then a lot of shoulder repairs or shoulder stuff because you're both hitting like you would lean in for football and take a hit or hockey. But then you also have like a big overhead, rotational component as you're following through with a shot. You might get hit or put on the ground, and so there's that component. The worst thing that I had happen that ended my lacrosse career was I got hit with a lacrosse ball in my larynx, and it fractured my larynx and collapsed my trachea. So it hit me. I went down. I popped back up. I scooped the ball. I ground balled it, cleared it, realized that after I threw the ball and the play was done, I was not breathing and I couldn't breathe. And I dropped to the deck again. And luckily, like I threw up, and that's what opened my larynx just enough for me to breathe again. But that ended up being a very long process and interfered with my academic pursuits at the time. And that was a big no-no in the master's program. So had to make a choice.
Yeah. What was the Achilles that you dealt with?
The Achilles was just a tendinopathy, like mid portion tendinopathy. And then what was funny is that like there were probably two or maybe three times that just serendipitous. I took a shot, like a ball hit me right on that Achilles tendon as I was playing. Just for whatever reason, like just playing. I was a defender, so I was getting like peppered with shots periodically. If you're like standing on the crease in front of the goal, you're probably going to take some shots here and there. And yeah, just for whatever reason, like two or three times while dealing in the same season with this like Achilles mid portion, just a ball would nail that area, and it would kind of cause like more of that very acute kind of inflammation in the area. And it may have just been increasing my awareness and sensitivity to the area. But yeah, even at that time, I knew like if I loaded my calf, if I just did like really heavy, slow calf raises, it automatically felt better. And if I didn't do that, or if I did too much running, it was worse. And no one told me that. I just kind of figured it out because I enjoyed training. And I was like, there's got to be something here. And then obviously, like reading more and getting more into it through academia, as well as just like reaching out to other people and podcasts and things like that at the time as I was in undergrad, it started becoming a little bit more clear. But yeah.
Yeah. Okay. This reminds me of I deal with a few people, a high school or college level, with well some Achilles, a lot of patellar tendons, and I'm like, the best case scenario is you get on the same page with the coaching staff, the athletic training staff, the strength conditioning staff, and they can like make a plan for you to settle this pain and stay active. Um, but that doesn't seem to be the norm that everyone's on the same page. And yeah, is that I don't know. That's probably got to be a frustration of yours. Someone dealing with like a chronic tendon pain, they just go to the physical therapist or the athletic trainer and they do the passive modalities. And then the weight room, they might be kind of like cut out of some things. And then the coaching staff, maybe they listen, maybe they don't. Yeah. Do you think there's any fix to this, or what are your thoughts with this? What's going on?
Well, to answer your first part, yes, it was very frustrating. It's frustrating when you understand a lot of this stuff at like great depth, and you work with it a lot very successfully outside of your work hours with private clients, and then like you see it happen in the elite world working with a young patient who theoretically should have a lot on their side to make a positive recovery, and they don't, because a lot of the time it's a lot of what you said. It's someone you're dealing with a DB or a wide receiver, and maybe they're dealing with a lot of patellar pain. Very typical like jumper's knee kind of presentation from a lot of really hard decels as they're preparing for training camp or just immediately after training camp. And it's like instead of doing things that may help them, like heavier slow resistance or even isometrics, for God's sakes, like even starting there, it's like all, well, we're just gonna cup it and we're gonna dry needle it and hopefully you'll be good for practice tomorrow. And it's like, well, you can feel kind of good, like you can relieve some pain through neuromodulation in the temporary space, but like if you just go back to practice tomorrow and there's really no game plan of how we're gonna like count your decels or moderate your speed or your reps. And then we're also not going to do anything that is known to be a little bit more tendon helpful in terms of loading in the weight room. We're just going to avoid any kind of like heavy knee loading. Yeah, two weeks goes by, and sometimes like they'll feel better, or like they sat out of practice, but we literally got like on a piece of paper that they're not allowed to do X, Y, and Z, meaning like any kind of patellar loading. for those 2 weeks, and that it would be handled by the athletic trainers, and then you go in and look at what they're doing, and it's like all passive modality or blood flow restriction is like what they just love for some reason, which you're again not going to get good tendon load. Like if high load is what we need for the tendon, you're not going to be achieving that with like 20 to 30% of a rep max doing BFR. So it was just kind of those things would happen for 2 weeks, and maybe they did stay out of practice, and the athlete would say like, "Oh man, I'm feeling really good," and it's like, "Yeah, I bet you are. Like, I'm really happy. Like, that's great. We can actually start working with you and start dosing in some, of these dynamic things and dosing in decelerations and see how you tolerate and just slowly build you up to these things." But instead, it was just like, "No, you can practice now, dude. You feel good." And sure enough, they'd just be in this like rehab purgatory, and then they're all scratching their heads like, "Oh my gosh, we just don't know what to do about like so and so's knee pain. It's so challenging." And it's like, no, it's really not that complicated. You're making it really complicated by doing really poor treatment again and again. And I think that there's just such a heavy reliance on manual therapy in the elite training spaces that it's kind of this mentality that I was thinking about how I would say this, and it's like I understand that if you have like a championship game or something really big is on the line, you're kind of just throwing whatever you can at it, full well knowing that there's a risk involved with that, and it's not gonna help. It's just like we got to get you through. Like, can you just play? But when you make every practice and every game important, like none of them are. So I think that gets done in the elite world. That like pain is just like this really scary, dangerous thing that needs to be avoided at all costs. And if you have pain, then like we're a bad medical team and we're not doing our job. And it's like, no, pain's a part of human experience and probably even more so a part of like an athlete experience trying to like edge on the pursuit of really, really high level performance and pushing their body to a level that like very few humans ever will in their lifetime. Yeah, pain is probably going to be a part of that equation at some point in the athlete's life, and how we deal with that is not all that complicated. People are complicated, not the treatment process. And so I just think that we just apply these like systems and methods and like modalities to situations that's probably inappropriate to, and then get frustrated and scratch our heads like, why isn't this working? It's like, well, they probably never worked to begin with in the way that you thought they did. So there's probably better methods. So yeah, I was kind of disillusioned by the high performance, quote unquote, high performance world and the elite sport world of just how bad a lot of it really was.
Yeah, I think I maybe got this from like Ebony Rio, Jill Cook, probably some other, but they have the pain and function are the two things they talk about, and it's usually like with the tendon pain, like let's try to keep it stable. Maybe it'll decrease a little bit, but it's the function that they're really focusing on. So like the patellar tendon would be like the how strong are the quads, or like how do you move when you do a plyometric exercise or something like that. Um, it sounds like from the athletic trainer and physical therapy world, it's like it almost is an over reliance on pain. Like you're only worried about pain and you ignore the function. And then once the pain, they feel better. Okay, go back to play. But it's like maybe the function has diminished and the pain is just going to get worse. And maybe they're more injury prone. Do you think that's an accurate thought that I have?
Yeah, I think that's partially part of it. Obviously there's a lot that goes into function. You can test a quad; it could be very strong. That doesn't mean they have the ability to decel and jump really well repeatedly. And there's a coordination factor. There's just a sheer amount of tolerance to that thing that we don't know how they're going to respond. Everybody responds a little bit differently. And I think on the flip side of that coin, you talked about the function piece. Well, we in pain we do chase pain a lot. And even a lot of the research that when people want to argue about certain treatments being effective, a lot of it is effective for what? And it's effective for pain reduction. And we already know from tendon research that you can have a pain reduction long before the tendon has actually changed, and that we see changes in the tendon still exist when pain and function have returned. So that doesn't mean that you're out of the woods yet. You still have like a potential risk factor in place, and that maybe some of these training modalities and the methods by which we arrive at a level of function need to be continued. But if the way that we are constantly teaching people to arrive at a better level of function or a reduction of pain is through very passive modality care and palliative care, that's not really a good long-term solution in any case for a tendon health related thing where we know this is a long-term thing, both from a pain ebbs and flows standpoint, as well as from a histological or morphological change that needs to happen in how that tendon materializes and responds and adapts to load. I mean, those things are much bigger pictures than just ouch, it hurts here, make the ouch go away. I mean, that sure, but it's a bigger story than that.
Yeah. Okay. So this whole like manual therapy, the cupping, dry needling, stretch, whatever it is, there, man, so many people have said it, and we were talking off air about this. You kind of have a different opinion on it, but they'll say they'll use all these things so that they can now get more load into the tendon. That people feel better, they can now exercise harder. Um, but you're thinking this could potentially be bad.
Potentially, yeah. I think to what end though? Not I wouldn't even look at it as good or bad. I think any physical therapist, if you've been treating in the space for long enough, you'll have experiences where I've had just as many patients had a very negative outcome with things like dry needling and passive modalities, where it made it so much worse, where it blew up their knee. And you may even have an experience where it's like, oh, we were able to really increase the load this person was able to tolerate in session, and the next day their knee was blown up. But I think beyond that, you may also have instances where it's not negative, where they were able to do a little bit more. They felt like a champion. We both high fived, and it was great. We just carried on. Where I think the problem comes is more of like the psychological nature and the passivity and what actually is causing the change. No matter how much you tell a patient that this thing, this modality that you're applying, even if you're on the evidence based side of it, saying that this does not cause tissue change, which we know it doesn't, you cannot take away the very lived experience that I had X amount of pain. You performed this thing with high face validity. I watched a needle go into an area that was hurting. You pulled that needle out and now it hurts less. No matter what I say about it, the person's going to believe, like, God damn, that needle was awesome. And every time that my knee blows up, I need that. And I don't want to create that narrative. I also don't think that it's all that helpful that if I can get a increase in load in a particular tendon in that instant, that necessarily means that I'm categorically doing better by the person and by their rehab process when we already know this is a very long standing thing that will ebb and flow over time and is a moving target based on how their sleep, how their nutrition, how their moods, behaviors, demands of life, all those things are going to ebb and flow and make this a moving target. Though I want them to have self-efficacy and have strategies and understand the principles behind what needs to happen in the tendon and how to pivot and how to think about their tendon the way I think about their tendon so that they have the strategies to manage it on their own versus watch me in this white coat and I'm Mr. Dr. Q and you're responsible to rely on me now to fix you. And I look super smart and it makes me look like a really good clinician because I have all these answers and I can make you feel good when you leave. But I don't think that that's a good healthcare model. I don't think that that's actually helping people in the long term because inevitably we know that when people have pain in a tendon, there's a pretty good chance that at some point in their life again, if they want to do those activities, they may have pain again. Right. And I don't want them to have to come to me every single time, like, yo, Q, give me that fix, dog. It's like, no, if you already understand the tendon principles, you have a lasting methodology that you can go to and a well of information that you can pull from again and again and again every time this comes up, not only in your knee, but probably somewhere else. Like it may happen in your shoulder in your 50s, and you're going to remember the conversations that we had. So I think that's actually changing healthcare and creating a lasting model of changing the health efficacy and literacy of our country versus the pandering to pain model where you come to me and I can get you out of pain. Look how awesome I am. I don't think that's a good model. I don't think it's a good model in high performance. I don't think it's a good model for general population. I don't think it's how healthcare should be practiced from an ethical standpoint, and morally, I disagree with it, and that's why I push pretty hard against it.
Yeah. Okay. How does that conversation go when they have this pain? You could do something, they feel great right away. Eh, You're talking like long term. We're not just trying to get by for another day, but we're thinking long term. How does that? Yeah, how do you have that conversation? And how are you determining maybe the length? Is it more like, okay, you've had this for a year, we can't expect this to go away in a day? Or what kind of things are you taking into account?
Well, I want to ask them first, what do you expect? You've been dealing with this tendon pain for the past 5 months, let's say. And you're coming to me for help. And I totally, man, I'm with you. Like I definitely want to get you out of this situation. We do not want to be here. This is a road to nowhere. And like, let's get you back to what you want to do. That's great. How long do you think this is going to take? And then that'd be the first question. I'll let them kind of riff on that. And then, maybe even a better question would be like, what's the longest amount of time that's acceptable to you to see real lasting changes, and what do those changes look like? Give me an idea of what success looks like and what is our timeline, because we may think that people are a lot more anxious about their pain, and then you listen to somebody like, ah, yeah, this is, I mean, it's lasted 5 months. It's probably going to take at least 3 months. And you're like, oh gosh, that was not at all what I was reading from the way that you were talking about it a second ago. I'm really glad I asked. And then, but like, what do they think is success? Is success like being able to jump the 40 inches and dunk again? Or is success like, oh, dude, like I just want to be able to go up and down stairs again? If I could, without surgery or without getting injections, you could show me a way that I could just walk up and down stairs without pain. That would give me a lot of hope that I am not relegated to a life of never dunking again. So I think just clarifying those questions on the front end, because if on the flip side, if somebody says like, yeah, I need to play tomorrow, like I have to dunk tomorrow, there's no other option. Okay, then fine. That, like, understand, I have to help you understand that like the tendon will not change between today and tomorrow. That's not a long enough time for there to actually be any kind of change in the tendon. We can do some things that will make it feel good, the same way that if I gave you a bottle of, ibuprofen and said, take a few of these, you could get through tomorrow. But what are we going to do after that? There has to be a conversation of like, what do you want life to look like beyond that? And I think that sometimes we just totally skip a lot of those questions and expectations and understanding of where people are coming from. And we just drive like, oh, yeah, I could fix that pain for you and watch how good I can be because that's what you're here for. And it's like, are they though? Are they really there for that? Like, clarify that. And I think that's how a lot of that conversation would go. Does that answer your question?
Yeah. Yeah. Um, More on that, this whole you being in the role you're in, and you probably see what's the percentage, maybe 80%, 90% of physical therapists, the athlete just wants to feel good and they want the cupping and the dry needling and the red light therapy and stuff. And these physical therapists will give it to them, but you don't feel right to being in a role to give that to them. Um, how, yeah, have you had, does it make it like, we were talking earlier about like being online. If you're just online, it's like a lonely place.
Yeah.
You need to find somewhere. But like, where could this actually be done? Have you found a place where this could exist, or it's just like the athlete wants it and they're going to find someone to pander to them?
Yeah, I think that the role that I had a little bit like in a strength and conditioning environment or working like at a gym, I think actually trainers, people that don't have medical degrees, actually have a little bit of a leg up in providing this type of care because there's already an expectation on the front end that like I'm not coming to see you as my strength and conditioning coach or as a trainer to fix my pain. I'm coming to you to train me, to like help me understand, to like play the long game, to strengthen these things or to get back to a level of activity to improve that function side. Versus when you have a medical degree, I think that the healthcare model has just made us culturally so indebted to it that like we need it to fix our pain all the time. And so it almost becomes a little bit more of a barrier when you have a healthcare degree because there is a little bit more of that expectation. Now, doing this online remotely, we know from the research, especially a lot of the evidence that came out during the COVID period of time, that like online based care, remote care, telehealth based care is just as good, if not better, in some levels of patient satisfaction as well as outcomes as in person care. So, if that's true, we also know that manual therapy can't be done via over the computer over a visual. So I kind of like that. It puts me in the seat of I'm a healthcare provider and I know something that will really help you and I can have in-depth conversations and walk you down the path of red flags and go over your MRI with you and talk about what your orthopedic surgeon said. We can have in-depth medical conversations, but I also have the advantage of we know that like I don't need to just pander to fixing your pain in this moment because you already are signing on for the long game and you're already signing on that like I would like to move and train. I just need a better path forward. And I think what's frustrating in the in-person field and the elite sport realm is that people and even gyms and private practice, they use this word all the time. They say, well, we got to get buy-in. We got to get buy-in from the patient. And it's like, yes, but the more that you perpetuate that game of getting buy-in via the things that we talked about just prior of pandering and palliative nature of care and passive modality type stuff, it only exists because that's our cultural norm. And you just feed that dragon by continuing to pander that need. The second you change the narrative and everybody across the country starts waking up to this idea that like maybe we should be speaking about these things a little bit differently and maybe more in line with the evidence, well, eventually it's a slow moving ship. It may take, 2 decades, but like that social norm changes. We're already seeing that happen where more and more people are a little bit more on board with like, yeah, the passive modality stuff, like it feels good, but it's not really giving me like people just don't feel like they know what to do after, and they want to talk to someone like, can you just give me a path forward of like what does actually training look like? Because I go see them once or twice a week, but then when I go back to the gym, I kind of like don't really know what's safe and what's not, like how much pain is okay, like what's programming, like oh my gosh, I've never heard of an RPE scale, like what's RIR, and it's like your therapist didn't like go over this with you, like that's criminal. They're really good at like sticking a red light on you and making you feel good in the moment and like warming up your muscle, but like they didn't talk to you about basic physiology or basic training parameters that you should adhere to in the gym and give you a program. Like that is not a physical therapist that I would trust. So I think that we just need to start playing a different game as a culture and as a society, and pretty soon a lot of those old modalities and the old way of doing things become very obsolete.
So I used to I used to do, you've heard of the RPR stuff when you rubbed your certain spots. Yeah. So I
Yep.
did the be activated. It was like the original, yeah, the original guy way back in the day.
Mhm.
And I had one of my buddies come with me. So like for many months we would do it sessions on each other. So I'd feel great after the session and I'd do
Mhm.
like I did a powerlifting meet after that. And then I moved to Ohio for my strength job. I didn't have him anymore. And I still tried to keep doing it, but I had to come to this thing of like, screw this system because I don't have someone to do it on me and I don't feel good anymore. But I did buy into it for like probably a year. I was like all about it. Um, Now I'm like the opposite. But for you, all these things you're kind of hating on the whole pandering stuff. Were you in positions where you had to do that in the past and you were kind of in the matrix of that?
Oh my God, yeah. I mean, early like in PT school, I mean, even when I worked at the Veterans Affairs, which was a great position, honestly. I mean, it was during kind of the tail end of COVID, and it was in California, and so the hospital system for the VA was really just averse to seeing patients. They wanted to try to keep as many people away from coming to the hospital as possible. And I just had a really good clinical instructor there at the VA who was like, "No, we're going to lie on our numbers." Of how many patients we're seeing because these people need help. Like we were catching like meningitis. We were catching people like guys that were saying like, yeah, I've been actually peeing blood for the last 2 days, and I couldn't get a hold of anybody at the VA, but you guys, I could get a hold of you. So, and it was like, yeah, you're going upstairs to go see a physiatrist like right now, dude. And like metastatic cancer, we were catching like crazy stuff that were coming in. So I was really appreciative of my experience there. However, um, this clinical instructor who I respect immensely, and in no way, shape, or form is this supposed to come across as a knock on him, but he was really into dry needling. In fact, he was the one for the military and the VA that everything west of the Mississippi, he was responsible for going and training other clinicians how to do dry needling. And so dry needling at the VA was huge. And I went through the entire body, head to toe, every level of the dry needling course. And at the end, I refused to accept my certification to be a dry needling specialist because I was like, I will not do this. And I didn't like it. I was the pincushion, so to speak. A lot of the other students didn't want to get poked with needles as often as I did, and I was like, sure, where do you want to stick me? Like, I don't care, because I just didn't care, and I would get poked everywhere, like between my fingers and toes, and like everywhere you can think of that's super uncomfortable and weird. Like, I was fine with it, and I did it on other folks. We also did a ton of like. Manipulations like joint manipulation type stuff, which is very chiropractic in nature, but a lot of PT dips their toes in that as well. I also went down a deep rabbit hole with like PNF and PRI related stuff because some of the clinicians in the early phases of my career had kind of leaned in that direction, came from the IFAST and Bill Hartman and some of the Mike Robertson type stuff. So they were very PRI driven in nature, and you still see that being very pervasive. Unfortunately, today this method and system continues to pervade our space. But I think I was exposed to a lot of it, and even required to do a lot of it, or that I would be treating an environment where that was the clinical norm, and it was kind of like if you didn't do it, you were wrong, and that was very uncomfortable. And I just kind of had to find a way to navigate that space. But I just knew from an early standpoint that like I wasn't going to do it. And even folks like Derek Miles like would just send me Dropbox folders just chuck full of all the current research on a lot of how this stuff was just total BS, and pointing out all the methodological flaws in a lot of the research papers that were being promoted to show any kind of positive effect of these things. And Derek, I love Derek, and I'll speak highly of him. He like went through all of his OCS like residency training, and then didn't like pass the exam, but he like refused the license after because he was like, this is such a stupid thing that this even exists. Like, I'm not having these letters by my name, even though it's easy to, because it's like too easy. Like, it wasn't challenging enough that he just felt like it felt immoral to like accept this like title. And that's kind of how I felt like dry needling. And I know it's like super extreme. Like, I'm not trying to sound like I'm morally above any other physical therapist because I don't do manual therapy. That is 100% not what I'm saying. So I'm sorry because people are going to be probably very upset by some of these things. I just think that you can do it. You can do a ton of it. You can do a lot of manual therapy, and if you find that it gives you, good patient relationships or helps you identify things, that's totally fine. It's just a lot of the narratives that come alongside it, just like we talked about off the air, that like we're going to say that, we're going to calm a knee down by decompressing it, decompressing your quad. We know that none of those modalities do that thing, but that's what we were going to say to the patient, and now they're going to hold on to that. That's a problem. You just promoted a non-evidence based language thing to that person that they're going to hold on to, and that we talked about also that like once you do a manual therapy and there's a very real response to that thing, you can't undo that. No matter what you say, they're gonna think that that thing caused the change, because if we're chasing pain, and pain means a lot to people and it means a lot of different things, and it's not that pain's all in your head, pain's real. But if you make them think that this little shiny gizmo, a gadget that I'm sticking in you, is going to be the thing that's like the cure all, and that you need me to do it every time you have this pain, I don't think that's a long lasting healthcare model that we should be promoting. That's all.
Yeah. Okay, so I think it wasn't at that Coach 'em Up conference. There's a few presentations, and we were kind of in the back just having our own conversation for a couple hours. But since then, I think we were talking about tendon rehab and how when you get a Achilles pain, patellar pain, it's like you used to be in plan A, which was you playing your sport and training and doing everything. And now you're in plan B, and it's like so many people just scrap everything. And it's like plan B is all the passive stuff and then maybe a little bit of rehab. But I I've said this now on a few phone consults where I'm like, I know people are becoming much less active than they were in plan A. If they were a basketball player, you used to play, you got 10 hours of cardio a week, and now you're rehabbing and you just got done with 10, you don't do 10 hours anymore. So it's like you're more unhealthy, you're less prepared, you're all these negative things. Is that when you're getting someone in a tendon rehab space, are you looking at it of like, let's stay as active as possible, try to stay in the original plan you have or you had in the past, and we're just going to try like cater a little bit to this like pain and lack of function?
Yeah, I think that's one of the things that I really like about operating more so as like a strength and conditioning coach, or like as a coach, a trainer, so to speak, is that like when somebody's dealing with, let's say, like back pain, or they're dealing with like tendon pain, to your point, yes, they will decrease activity, especially if they're an athlete. Like, they're no longer participating in practice. I see that as a huge opportunity to pull other levers. And like, how do we start programming other things that like make sense now? It all comes down to programming. So if somebody's not as active, even a gen pop person, like let's say somebody that just plays basketball on the weekends, and they're not like an elite level, but they just enjoy it, and but now they've been dealing with an Achilles tendinopathy, and it's really interfering with playing to the point where they've had to stop and they don't really know what to do. Well, that person, that I'm talking with, who's in their mid 30s, they may not have had visible abs for the past like 5 years. Like, it'd be kind of sweet to like maybe chase that a little bit. Like, what's your VO2 max? Like, we don't have to measure it necessarily, especially if you're just going to like, Planet Fitness. Like, you're not going to measure your VO2 max most likely, because both you don't care about it, and maybe we don't have a metabolic cart to accurately measure it necessarily. But like, we can pull a lot of other levers in training from a cardiovascular standpoint. We already know that metabolic health is significantly related to the outcomes that happen with tendon. That's why we see in elderly folks that are very sedentary and inactive, they also have tendinopathy. Well, if tendon pain is all overuse, how are we going to say that somebody who's very sedentary or older is getting tendinopathy? Well, a lot of it does have to do with like diabetic factors and these chronic disease pathologies and metabolic health, and the way that that impacts a tendon and recovery, and everything that comes from tissue histological nature of healing. Like, that all is wrapped into this thing, even for a young athlete, that we want to keep their metabolic health very high. That the way that again, Derek Miles, like he explains it. if you look at, and I use this analogy a lot with like survivor's bias, and if you just Google like survivorship bias, you'll see this analogy being used. It's with the World War II airplanes, and maybe you've seen or heard
Yeah,
this. I see
yeah.
you nodding your heads, but um, would it be useful to
Oh,
briefly
go
go
ahead,
over that?
explain
Or
it. Yeah.
okay, so World War II, planes getting shot down. We got to figure out what's going on with these planes, how to armor them. Let's look at all the planes in our hangar. Where's the bullet holes? Great. Bullet holes are here, here, and here. Armor those areas, send the planes back out. They did that, no change. Same amount of planes getting shot down. Well, then come to a little bit later realization that, like, oh, well, we were looking at all the survivor planes, all the ones that were coming back, not the ones that were actually getting shot down. And I think that it's the analogy, both from a survivorship thing, now translates into more of like becoming very myopic in rehab, where yes, the person has a knee pain, but we don't just armor the knee and forget about everything else that has to be in high function and high system in order for them to, go onto the quote unquote like battlefield, so to speak, right? That if they're going to go back to playing, we want that knee or we want that Achilles or this tendon issue to be the absolute very, very last thing lagging, and that we get a sweet opportunity, especially if it's somebody like in training camp or in season of football. Like we know that general fitness is probably going to generally decline over the course of a season, and that's okay because typically in the off season you're going to get fitness rising, but you're also getting fatigue to rise. So a lot of that fatigue is masking your fitness, and your performance outputs are probably going to decrease a little bit. That's just normal elements of physiology and training. But now we're looking at this in terms of like, well, we already know that your fitness was kind of coming down maybe because we're not training as hard. Now you have this like kind of gift, this opportunity and this injury where we can really, really improve fitness in a lot of other areas, really improve strength in a lot of other areas, that in 3 or 4 weeks from now, when you do feel a little bit better, that you could return to play, like you're a tank, you're the best you've ever been. And I think just so often, yes, you're 100% right. They become in like the salvage pile in the junkyard of like, oh, here's plan B. And it's just like, yeah, just remedial stuff. And I get that, managing stress, like kids, especially if we're talking about college sports, like the academic stress of that, even high school sports now, like there's a significant social and academic stress, as well as like sleep and alcohol and poor nutrition patterns, that they're kids, man. So like, all that stuff isn't going to be dialed. But then I think, even in terms of the older adult or the middle-aged adult who's dealing with this stuff, which is a big part of the populations that I'm sure you and I both deal with as people that just want to be active, there's probably a lot of other levers that that person could pull that, their cardiovascular health may have been on the back burner a little bit for a while. And that's a huge lever that we can pull because there's a lot of ways to cardiovascular train that don't involve running per se that may aggravate a knee or an Achilles tendon injury, that we can really maximize that and probably going to recover a little bit faster and feel better anyways. So I think those are all really important parts of rehab.
I I don't have an answer for this, but the myself being a basketball player is like any other form of cardio is just miserable and boring. How do you deal with the psychological impact? I think it's been talked about with like Osgood Schlatter when these kids have it and they completely remove them and now they're not playing with their friends anymore. They're just sitting on the sidelines and like the psychological impact it has on a young kid. Yeah, how do you deal with that if someone has to be removed from the sport, or are you trying to keep them involved just with a little bit of guidelines?
That first, like, can we just set constraints around what it is that you can do? So, in the football world, it would be more like, how much of indie or positional drills could you be around? How much can you be around your coach? How much can you be in these drills? And instead of like, if I was dealing with a hamstring related injury, and they're able to kind of start moving, but we're still a couple weeks away from probably full out sprinting. Well, okay, instead of going to the 10-yard line, or instead of going to the cone that's 10 or 7 yards away, let's just tighten that up to 5. You can still do the drill, you can still participate in a reasonable fashion and be with your team, and as long as it's not going to interrupt the drill drastically, like you can still participate to some level. And I think that that's really huge for them from the psychological perspective, as well as just getting some really good reps. You can count that as practice volume, track it on a GPS or watch them go and see about how many touches they get, how many decels. Now, that was part of rehab. I think that the same way that we approach when dealing with like a long distance runner, that like the running. I know a lot of Greg Lehman's work, talks about that. Like the running, the doing is the fixing. And I think a lot of participation in the sport can be restorative in nature if done correctly. There's some things that it just can't. Like I was talking with an individual yesterday that they play basketball on the weekend and it's part of a league. And it's like when you sign up, you're on the roster and the roster size is limited. And when you play, like you're playing for an hour minimum. Like that's just, you either are or you aren't. It's very dichotomous. So for him, it was more of like the conversation became, do you have a friend that you could just go to the gym with and do some one-on-one stuff? Do you have a friend that you could just go play around and shoot horse? Just play like little mini games just to keep interaction with the thing that you love, even though we know it's nowhere near what you want to be doing yet. We know that this is not going to last forever. This is not like your life now. This is just a now thing, but it beats the hell out of just like sitting on a knee extension machine or just a calf raise machine. Like at least you're in the gym shooting a ball and interacting with your buddy. So I think, yes, that's a huge factor in this is the psychological piece. And then I think another question that we start gearing towards is like, what are other goals that help you feel like we're making progress? So the knee is really painful and you probably have two or three things that you would love to get back to doing with the knee. What's your bench like? Do you like benching? What's your hamstring strength like? What would feel like really cool to be able to do? Like, oh man, it'd be sweet to actually be able to do like a Nordic. That'd be really fun. Like that's something that some people will just rattle off. Now, I don't think the Nordic hamstring curl is like uniquely important for their knee. I wouldn't ever tell them that, but it's like sick, dude. We can do some extra hamstring work then, and let's chase that thing. And like, let's make that like a really cool thing that when you do that, yeah, like, the knee is still coming along. It's still, a little up and down here and there. It's way better than it was, and it's not 100%, but like I can do a Nordic now, which is dope. So I think like things like that, you just start attaching, and I think a lot of this, there's so much carryover with psych therapy to physical therapy. And a lot of the thing that you talk about in psych therapy is like when somebody's having depressive episodes is like finding ways that they can stay attached, instead of detaching and recluding from the world. It's like, what are things that make you feel more attached, more a part of things, more a part of relationships, more beholden to like be present in the moment. And I think by setting these like some of these adjacent goals that are still training and still physical, it can help them feel like, yeah, I am still attached to training. I am still attached to my physical body that I enjoy being in, that I have pursuits in, even though this one thing is really shitty right now and it's hurting, my psychological health and it's taking me away from things I really enjoy. I have all of these other levers that now I can pull that help me feel like I'm still a resilient human that can do things and interact in this world and training space that, I'm not just relegated to like, I got to get a PT now.
Hmm. Do you? I'm thinking back when I was at college strength conditioning, and you'd have someone injured or like maybe they'd come back from ACL, whatever injury it was, and you'd see everyone practicing on the basketball court for 2 hours, and then this one injured athlete is sitting there watching, like almost like a coach, for the 2 hours, and yeah, I feel like I gave up on college because it's just bad pay and too many people I was dealing with, and I feel like that's not a common thing, right? To take someone injured like that and be like, okay, let's do just as much work, maybe if not even more, to keep your qualities high or keep you active and keep you all the benefits of like that. Um, yeah, is there a lot of pushback when you try to present these type of ideas that this injured person should be as active as possible, or I think the pushback I would have got was the athletic trainers because I'm just a strength coach. They'd be like, "No, they're recovering. They need their rest," or something like that. You know?
Yeah, for sure. There is a lot of that. I mean, even with like football guys, the UNC guys, we'd do like mini games or like mini routes. Just try to interact with play. And it was like really like, hey, for a hamstring or for like an ankle injury, like what percentage do you feel like you're at today relative to 100%, means you could practice at full tilt? And they'd be like, yeah, I'm probably like 50% go. Sweet. We're gonna run some easy slant routes or some like across the center routes at 50%. Just down throttle a little bit, but I just want to throw balls to you, dude. Like it's gonna be fun. Let's just like enjoy this time. And I'd sit out there and play with them. And so it's one of the other coaches, AJ Blue. We would just kind of play with the guys sometimes, and that was massive. You're right; it doesn't happen a lot, and I think the pushback we got was from the medical team, being mostly the athletic trainers, and there was like such an aversion, like such a fear of like anything going wrong. And I get it because when you work in an environment where the time loss to injury that's, marked on paper is directly related to whether you get to keep your job at the end of the season or not, like, you're probably gonna be a little bit averse to taking risks or to, like, exposing people, so you're just afraid of everything because, like, if anything were to go wrong, if you were working with an athlete, even if it was completely reasonable, like, you talked to, Peter Meliaris, right? And he was doing the isometrics on a non-painful Achilles, and it popped on the guy. Just and it was like a total win thing. It was just like, "Hey, we're doing this isometric on your painful side. Do you wanna just hit a set, on your non-painful side? Sure, why not?" And his Achilles ruptures. Like, if that were to happen in a sports setting, it's like you're gonna lose your job. Even though that's completely not even remotely on the radar. And here's a guy, Peter Meliaris, who's like one of the leading tendon experts in the world with Achilles tendon, and it literally happened to him. But that's just like this huge unacceptable thing that could ever be the case in elite sport. And you're just seen as a firefighter. Like Eric Maida talks about that. Like a lot of people with ACLs, it's like, and if you're in elite sport realm, it's like, well, you're just a firefighter, put out fires, and anybody can put out fire. You have the same degree as they do, so you guys all do the same thing. And it's like, you're a coach, and over there at the D3 school, he's a coach, but you guys don't do the same level of coaching, do you? Like, it's not, but that's how the medical team is looked at. Is like, if you have this license, then you're just good. You just do this thing. You just put out the fire, and it's easy. And medicine is just this like known thing that, like, yeah, you guys just find the problem, fix the problem. It's a car, it's a mechanic, just do the thing. But it's not. It's super nuanced, and it's way complicated, and people are complicated, and like there's a lot of moving targets, and sometimes you could do all the right things and things just don't pan out. What worked for the last 10 people, the 11th person, for whatever reason, it's totally haywire. Same presentation, but it's just not working and you got to pivot. And why? And why is the timeline longer for that person? You can't sit across the desk at a staff meeting and tell the head coach these things and explain nuance because they don't give a shit. They want the player ready by this game. And so, yeah, I understand that the athletic trainers like watch you do this stuff and they're like, oh my God, like, you just see their butts pucker and you get it because like you have no freedom, you have no nuance in the healthcare space.
What's the solution for that?
I think it's going to take a lot more folks to give pushback, like myself. I think what ends up happening is you get folks that are young who go into these spaces and they're not willing to ruffle feathers. They just want to, play the game and do whatever it takes just to wear the logo. And whatever was done before is just being done. I don't think that you're going to necessarily change minds, but I think by having more people on board with this, you're going to start seeing cultural shifts slowly over time. I think as the old guard either retires out or dies out, whatever happens first, will also be helpful because I think there's just a lot of people that are gatekeepers in the community in the elite performance realm that did things 20, 30 years ago, and that's just how it was done and they fail to see that just because they had some decent results along the way that it may not be the most efficient or best way to do something. So I think that it's just going to take a lot of change to happen, and unfortunately the way that the model is set up where now you've placed a lot of power in the hands of the patient, essentially the player, who does not have the knowledge or ability to fully understand the nuance of how these things work, and they are just seeking out a lot of pain stuff, and if you don't give that, they're going to find someone in the sport world who will. I think it's going to take people to say and stand up and say like, no, that's not how our culture and operation works here, and we're not going to do that. This is what we're going to do. And once they start doing that, and then also following that up with like, we get the same results, if not better, over the long term, which is very possible. I've been doing this online for 4.5 years almost now, and have just as many success stories by not touching a patient at all. Even high level professional playing athletes via remote care like this, it's possible to have good results. And I think it's just going to keep taking more and more of that before people, change. But it's an
Yeah.
uphill battle for sure.
The
And yeah,
I thought one thing I think pretty often I felt it at the university was the title I had was strength coach, and the athletic trainer was like automatically above me. Um, but I was
Yeah.
also young. I was like 30 and these people are like 50, 60, you know, and they can always bring the resume and say, I've been doing this 30 years. But one thing I started to do, because we had a soccer coach come in, Brian Schrum, who was a ex-strength coach, really knowledgeable on physiology, injury. Such a great philosophy. I learned so much from the guy. But I started doing spike ball for warm-ups, like with women's soccer or doing dumb games, you know?
Yeah.
And some of the athletic trainers would not come to the warm-up because they were scared that someone would get hurt, you know? And
Yeah.
I was lucky that I had Brian support because like he understood that like it's better to do this than the same old dynamic warm up and everyone hates their experience and they go in the weight room and they're miserable. You go play a game and a lot of them are like having fun and sure there's a higher chance of injury. But what the athletic trainers would say, which I kind of was like, okay, that's fair. They would say, it's okay if they get hurt in practice, but they shouldn't be getting hurt in what you're doing, you know? And I'm like,
Right.
I kind of understand, but also like that's like saying what I'm doing is useless
Yeah.
when it's not.
For sure. Well, I think a lot of that centers around, like, why why do we even participate in sports to begin with, right? Like, to have fun. So you're doing something that's fun. Yeah, there's risk associated with that fun that I've chosen to have, but that's also why I play sports because it's fun. And I think we've just gotten into such a like capitalistic model where winning is everything and we have to gain wins at all costs and all of our financial success and our donors and boosters and the recruits we get next year and the health of this program relies upon the W's that we get. And if when you make winning the only thing that matters, and the only thing that measures success is the W, the scoreboard, then yeah, it robs all of the reason why any of these kids participated in sport to begin with. And I felt that as an athlete. I mean, I felt like by the end of my college lacrosse career, I was like, this isn't fun at all. Like this is no more. This is 100% a business and this is not really all that fun anymore. Like I didn't sign up for this. Like when I was playing lacrosse in high school, I was like, dude, I looked forward to like nothing more in my life. Every morning I woke up and every night I went to sleep. I was looking forward to the next time I got to play lacrosse. I did not feel like that at all whatsoever in college. It was totally a job. It was so much pressure. It was everything was on the line every time. And so, yeah, I think we have a systemic like cultural issue with that as well. And our measures of like what is successful is kind of unfortunately skewed. And I think that dictates a lot of the models that we fall into, the same way that the healthcare model, if all we care about is managing pain and palliative nature of care, then yeah, you're probably going to choose like modalities and paths of care and treatment that are associated with short-term reduction of pain if that's really the only measurement of success. But like I think you just move the goalpost to like something else that means and matters more to healthcare as a whole, to like the longevity of people's health, to health literacy, to staying active into older years. And like now you have different goals that you can do different things that actually like create longer lasting impact on like non-communicable diseases and things like that. So I think that's, part of this conversation. And it's not that like you have to be this like ultra like moral code person. I get winning matters, but like, yeah, dude, that's just a funny reflection of like, yeah, we enjoy training with Jake. This is super fun. This like is why I came to school to play sports. And then it's like you're getting punished. Like, no, that's too risky. You can't have fun. That's too much enjoyment. There's a risk there that they can't play, and that means if they can't play, then we're not going to get W's. And it's like, well, that's not why they came here in the first place. So, anyways,
How do you do when someone we're talking about the focus on the over focus on pain and all the negative to that when someone has a flare up because with tendon rehab it's so common that like you think you have the perfect plan and you're dosing them properly and then maybe after the session or the next morning it's like they have this huge flare up in pain of like 5 out of 10 points and they're like so concerned that things are going bad. What kind of conversation do you have with these people?
yeah, that's a good question. I think that first to back up even like just I know you've talked about this and other experts have talked about this, like the difference between long ISOs and like maybe early mitigation of pain versus like more of the now more popular Berlin protocol and doing these shorter contractions with a little bit more force output to get a higher strain in the tendon. I get that, and we should be doing things like that. And early on, you are doing things that are probably less effective from a tissue standpoint because you're trying to get the person to interact with their pain at a psychological level that's more healthy, that they can see that there's some hope for resilience, that yes, you can work this thing, that load is medicine, all of these types of things that we're trying to help them understand versus the avoidance model. Now, when they have and I think first of all, I would even back up further and say I warn people on the front end of working with me that like flare ups are normal. Like during this process, this is not going to be a linear thing. And I think the conversation that happens on the front end, as well as the immediately in the moment when they're having their flare up, I relate it to like psychology again. If I was working with someone with and not that I'm a psychologist, but if somebody was being seen for depression or anxiety, does that mean that just because you've worked on it and you have like methods in place to help you manage your anxiety that you're never going to have anxiety ever again? Like that's ridiculous. We would never think that. The same way that in a relationship that's really healthy and good with somebody else, a loved one, like to say that you're never going to argue with that person ever again is also just as ridiculous. Like that's a part of human experience in every aspect that you look at, no matter what you want to talk about, work environments, any physical space that we occupy, any social space that we occupy, flare ups or things that slightly go a little bit off course than what we expected is just totally normal and we don't even bat an eye. But then all of a sudden it happens in rehab and we're like, oh, this isn't right. Like this is bad. And it's like, no, don't you realize that there's so many potential inputs? Like if we really did truly an active reflection and there was like a video camera on your life at all times for the past 3 days, what could you identify as potentially contributing to why the knee maybe hurting more today than it did last week? And let's just be really honest about that. And maybe there's something in there, maybe there's not, because what also happens is like they can make the same poor decisions 3 times in a row and not have a bad outcome, like poor sleep or whatever it might be, or overload. And then on that fourth time, all of that stuff just decides, boom, now we're going to have a response. Why? Well, we don't know. And that's perfectly fine, but just like expect it. And we just adjust. That doesn't mean that like everything is bad. It's a course correction. It's a hiccup, not a total step back. And when these things happen, as they'll happen now, and guess what? 10 years from now, you're probably going to have something happen again. Human experience. It could be low back pain. It could be shoulder pain. You're going to stub your toe. Dude, I don't know. Like something's going to happen. And as long as you have some management strategies and a way to like conceptualize and reframe this thing that you're thinking is really, really bad, it's probably not as bad as you think. It probably will be gone in another 2 or 3 days and we'll be back on track. Just goose for Baja, take a deep breath, you'll be okay. I think these types of conversations on the front end of things make it a lot easier on the back end. And then when they do pop up, it's almost a little bit more expected, even if there is like an emotional response, just helping them walk down that path or how, like, what is now starting over like if you have pain, again, that same question that I asked, like, what is your expectation of how long this should take to reduce? What would it mean to you if tomorrow it's better? What are you going to do about it? What if tomorrow it's the same? What does that mean to you? Like, let's actually hash this out and like, let's examine and roll around it. And how bad is it really? Because you're telling me it's really bad, but like, let's actually examine it and pull it out of this like dark hole that you're thinking it's in. And the more you talk about and like actually look at it, it's probably not as bad as you think or as scary. And I think that we could probably find a meaningful path forward where it's like you don't have to avoid training. Like, you know what I mean? So
Yeah.
does that answer your question?
Yeah.
I don't know
Yeah.
if
Yeah.
it's too
No, it
vague
does. No,
and
it's perfect. That's I've had to change, but I forget. I've had to change a lot of my initial conversations with people when it's like I sometimes forget to ask how bad it is. They'll just be like, I have Achilles mid portion pain and talk for 30 minutes, and I never asked them how bad it was. So I do remember to do that sometimes because sometimes it's like it's a 2 out of 10, and I'm just like, oh my God, like you really want to get this down to a 0? Like, okay. But if it's like a 7, then I'm like, all right, I know what I'm dealing with. But the flare ups too is like if someone's regularly a 3 out of 10 and they're like, dude, I had a flare up. I'm like, well, what's it on the scale? And I get the scale's imperfect, but it kind of helps. They're like, it's a 4 out of 10 now. And I'm like, that's not a flare up. Like you don't get to say that's a flare up because it's like you're doing disservice to the actual flare ups. But
right.
yeah, I think a lot of it comes luckily for me and probably for yourself is like people regard me as like a person that does a lot of tendon stuff, so like they'll take my word and they have someone to converse with and kind of guide them. But outside of that, you get a flare up and they're just thinking like all of the quad strength they built is gone, all of the other function is gone, and now their knee hurts even worse than it did before, and it's like, yeah, that's not true.
Right. Yeah, and I don't even think that I probably don't do this very often, and I know there's a lot of really high level good clinicians that I respect immensely that don't go into a lot of the pain science stuff, and I don't think it's always necessary. I don't think it's always very useful. Every now and then, though, I'll get patients that really care about that. A lot of the clients that I'll see are other coaches or other PTs, and so they're kind of like already in that headspace where they're maybe interested in it or curious, and I just have to remind them that, like, yeah, like, dude, pain's like really complicated. There's a lot of things that play into pain. It doesn't mean that pain's in your head. Pain is extremely real. Your experience is very real. The same way that, like, even if I use psych therapy a ton, but like the same way that if you're having depression, like I might not be able to measure an exact chemical change that happened in your brain when you're having a depressive episode. Maybe there's nothing. That doesn't mean that something very real isn't causing, depression, that you're not having very real chemical changes, and it also doesn't take away from your very real lived experience right now that this really sucks. But to say that, like, every time that I have depression, or now transitioning back into the analogy of every time my knee hurts, that, like, I'm really doing damage and this is very bad, that also probably wouldn't be, very prudent or very wise to think that. So I think just kind of relating it to other things that people tend to experience in life a little bit more frequently and have different outcomes, like, and then relating it back to their knee, and every person may be different. Like I can use like their job or things that they're interested in, and like, oh, you know how you surf. You told me you were super into wake surfing, and you really like. Did you get up every time? And are there days like for whatever reason you didn't get up, and you've done it 100 times, and like you just didn't get up on the wake surf that one time? Like, why did that happen? Like, I don't know. It just I don't know. Just kind of didn't happen that time, and I felt like an idiot. Like, yeah, dude. Like, that's life, brother. Like, it's gonna happen again, and that's okay. So I think like using little examples like that certainly, yeah, can help. And you're right too. You made a great point. Like, really, just asking like, how bad is it? Like, and like you'll find out pretty soon. Sometimes it's like, it's not even that bad. Like, yeah, we don't have to panic.
Yeah, maybe they just wanted a friend to talk to or something.
Yeah,
Um, yeah, one thing that you get with these, like, I'm thinking the insertional Achilles, um, you can get that compression pain if you're walking on the flat, or like patellar tendon sitting on the bus, it can flare up. Proximal hamstring if you sit on it, glute med if you cross the leg, maybe like elbow tendons too. Like, so that this pain, because a lot of what we've talked about is like this pain with activity. Um, when they get pain like during the day and now they're thinking about it all the time, what type of conversations are you having? Are you trying to get them out of that pain? Like for me, if they're sitting on a bus, I'm just like, well, don't sit, straighten your legs. Try to get in positions where you can straighten your legs so you don't have to go back in this pain and get reminded that you have pain. Yeah, how are you dealing with pain when they get it from like just random points during the day? Are you trying to get them out of those positions? Are you educating them on maybe what you think, how they should be thinking about it?
for sure. All of those things matter a lot. I think I try to use language or have like a demeanor where none of those things come across as like, oh yeah, if you're sitting on the bus and you're bending that knee and you're getting all that compressive load and your tendon starts hurting, like that's not good. We don't want that. Like you got to stand or straighten your legs. Instead of that kind of language, because like that's probably not true. Like they're not like really doing like irreversible harm or damage to their knee. It just feels bad. It's just uncomfortable. And the more time they spend in that uncomfortable thing ruminating on it, like it's probably gonna just play into the predictive processing model of their brain that's working with this pain thing, that like it's going to just ruminate longer. So instead of having that language, I'd rather just say like, hey, so here's some just potential factors like that we know happen with tendons. Like of these things, what are things in your life that you feel like may contribute to that? What does your day-to-day life look like? What do you do for work? What do you have to do with the kids on a day-to-day life? Or, tell me a bit more about yourself and your profession and what like a day in your life kind of typically looks like. And like, if we know that these things could potentially just aggravate things or just make your life a little bit more full of friction when dealing with this, like let's just try to see what we can do to mitigate that. Like the gluteal tendon type stuff, like yeah, sleeping on your side is probably not going to feel great on that side. Is it possible to sleep on your back or the other side a little bit more frequently? Or like, do you like how deep is your do you drive a sedan, or are you like up high in a truck where you can like kind of allow your hip flexion to be a little bit less, or like your office chair, could we just raise that up or give you like a little bit of a seat wedge so you're not sitting in like deeper hip positions all day long or crossing the legs? Like that could probably help move things along. We know that, it's not dangerous. It's just like going to cause a lot less friction in your life, and you'll probably get. So I try to use that type of language, but absolutely, like because most of my consultations and the work that I do is like this via just remote type stuff. Like I even open up the conversations with, "Hey, I know you filled out on your questionnaire that you've been dealing with this knee related stuff for quite a while, and we're totally going to get into that. I'm really excited to talk to you about that. Before we do any of that, just tell me about you. Just tell me about your life. Like, what do you do for work? How'd you find me? What interests you about training? Like, just tell me about yourself. I just want to know." And so I let them just open the door. And man, in that little subjective conversation of what their life is, what they do for work, you're going to find more treatment strategies just out of that initial like 10 to 15 minutes than a lot of the other stuff they're going to tell you about their specific pain, because you're going to start seeing what is the shape and look of this person's life, and it just gives you really easy touch points of knowing like, yeah, dude, maybe some pretty frequent tendon load could be helpful for some people, but not for this person because they only have 2 days a week they can train. So that changes my treatment course of action. Or like I'm dealing with this woman who she has a run club every Tuesday, and then on the Saturdays it's really her only time that she can get away from her family and have her husband watch her kids. So like when she wants to run, those are her two moments that she can really run, and the other days she's not going to run. So I have to make sure that I'm programming her runs in a way that keeps her distracted, that keeps the element of like I'm getting out away from my family and work and I can do something that's enjoyable to me. Like that totally changes the conversation of now what I take from the research of what's technically the most, effective thing that we found for the principle of loading, but like how do I apply it to this very unique person situation who has a lot of other barriers and constraints, but you won't know that unless you talk about all these other lifestyle factors. So I think about it in terms of that, not just sitting on a bus, not just wearing certain shoes like a minimalist shoe versus a heel lift, or thinking about which side or crossing the leg. I think it expands even more than that.
Mm. Yeah, that's something I'll have to do. Uh, I don't think I've ever. Sometimes I'll get an idea of what a person's life is like, but yeah, I think that would help quite a bit. Um, okay, your glute med. You had glute med tendinopathy. I was telling
Yeah.
you like a couple years ago, the little bit I read was just like, oh, it's a thing with postmenopausal women or wider hips, and then recently quite a few males, like high performing men, getting glute med tendinopathy. Yeah, tell me your story with that.
Yeah, I've had it on both sides at different times. I remember another really frustrating example in PT school. I had it on my left side, and I kind of had an inkling idea of like I thought I knew what it was. I was like, yeah, probably greater trochanteric pain. It's right on the spot. Hurts when I do like a very unilateral loaded thing. Pretty confident it's a glute med thing. I went and saw like three of my professors at the time in PT school, and they were all like, oh, it's radiating down, your thigh, so it's quad, it's vastus lateralis, or it's like biceps femoris, like it's a hamstring. We just can't figure it out. Like I remember one of the guys just used a Graston tool and scraped the shit out of my like IT band and quad, and it was super blue and black and blue and bruised up, and it hurt way worse. Like just rubbing the crap out of my greater trochanteric process with the thing, like right where it was painful. And dude, that made it 30 times worse for like 2 weeks. It made it so much worse, and I was like, "I'm never trusting these people again." That was so stupid because I already knew what was going on. I just kinda wanted to see what they would do and, like, entertain them enough to, like, show how dumb they were in a way, and it totally panned out that way, and it was bad. I dealt with it on the left, and then, basically how I treated it was, the same way I would treat, other folks, is I just, limited my squat depth. If I got deep below a certain point, it lit up, and then if I crossed that barrier on the way back up out of the hole, hurt again. If I limited that depth, it didn't bother me. Same with like split squat. I could do, single leg work, step up, step down, lunges. I just had to be under certain constraints, whether that was range of motion or loads or speed. I could deal with that. I could do, running related stuff at limited levels, typically like hill related stuff, just to kind of make me feel like I was working kind of hard because it was uphill, and reducing a little bit of the impact load seemed to kind of help, even though I was going into deeper ranges of hip flexion. So maybe there's some counterintuitivism there at play, but really just a lot of ISO work, a lot of side planking and unilateral work. And then I got it on my other side maybe a year ago now, and it was just doing a ton of of strength work in conjunction with also ramping up a lot of speed work and a lot of change of direction. So it was just a lot of levers being pulled all at the same time, as is typically the case. Yeah, and I think for me, I'm probably a little bit more prone to that over other Achilles or like Achilles or patellar tendinopathy, other tendinopathy sites because I'm just really good unilaterally. Ever since I was really young, like even an 18-year-old out of high school, like I could easily lunge like 365, 375, no problem, like for 5 or 6 reps each side. Like as a lacrosse player that weighed like 200 pounds, like I could just lunge a lot. But if I tried to squat that, it would be like really, really challenging or just abysmal. I've also had like a really, really strong deadlift for a really long time. So I just liked putting a lot of load in my hips to begin with. And so I think just in a lot of the unilateral work that I tend to gravitate towards because I enjoy it, like rear foot elevated split squats, reverse lunges, those types of things, I'm just naturally going to be putting a little bit more emphasis and load into that particular group of tendons in that area. And, you tend to gravitate towards the things you're good at. If you're really good at dunking and jumping, you're probably going to do more of that and maybe have jumper's knee a little bit more often. If you're really good at hinging and single leg work, you're probably going to do a little bit more of that more often and maybe have a higher likelihood of developing some issues along the way in that category.
Yeah, yeah. Okay. I was gonna ask this earlier with you talking about some of these like hamstring injuries, and I think Derek Hansen kind of popularized, or maybe kind of when you're coming back from a hamstring strain is like the I forget the phrase you had, but it's like the running is like the rehab, for that hamstring
Hmm.
issue. Just dosing the running, decreasing the intensity, whatever it is, because
Yeah.
you
The
can run
fixing,
and be
yeah,
sorry,
was
what's that?
the fixing is the doing, or the
Yeah.
doing is the fixing.
Okay. Yeah, yeah. With the but I've had a hard time with the I probably asked other people with the Achilles or with the calf, like a soleus strain or something like that, because you jog and you're already loading it quite a bit, and then you
Tons.
sprint and you're loading it. So it's like, how do you? It works for the hamstring, but it's not going to work for the calf. Or where do you stand there?
Oh, 100%. Yeah, the methods that you use to treat like a patellar tendinopathy in terms of like, oh, we're gonna maybe use a hill or we're gonna use a little bit of different foot strike pattern or even just increasing your cadence. Like that's a really common one for patellofemoral joint pain as well as patellar tendinopathy for runners is like just increasing the step count without increasing your speed can significantly spread that impulse curve a little flatter and your peak loads are just a little bit lower so you can tolerate it better and get away with it. Not true for the calf. Whether you are running slow or fast, or you have a fast cadence or a slower one, the calf is still going to be loaded a lot. Even some of the more recent research, like softer surfaces, we would naturally think that just running on a really cushiony soft surface would be better. It's not. Actually, for Achilles tendinopathy, you actually then increase the impulse because you're spending longer in plantar flexion and plantar flexion moments when you run on a softer surface versus a stiff surface. So even though in a stiff surface you get higher impulse or peak impulse, the actual overall area under the curve in a stiffer surface is a lot less. So a lot less work is being required of that tendon versus when you're on a soft surface, it's required to do more work. So that's one thing. The other thing that was done in a study where they did 5K runners, they had people run with a very heel strike or midfoot or forefoot and found that the difference between a heel strike pattern and a forefoot strike pattern over the course of a 5K was 49 times the amount of load in a four strike person versus a heel strike person. So, like, now that's also to say that no matter what, like if you're running, it's still a significant amount of load. So we just have to go about these things a little bit different. Where I tend to use things like an elliptical, like a bike a lot more often. I'll even have people like post Achilles rupture when we're just starting out. I've had people literally take duct tape and tape a shoe in the middle of the pedal of the foot plate so that it's not as forefoot loading. It's kind of more in that midfoot so they can just kind of push through their ankle bone and get like a lot of reps on a bike and then slowly move it back, week over week until they're just normal pedaling. But versus like doing a clip in on like a Peloton where it's 100% forefoot right from the get go, trying to like kind of just get some active tension in that area, but really spread that impulse curve very, very flat as possible can be very helpful. But yeah, man, running is just either you're running or you're not with an Achilles, it seems like, and it's really like the dose is going to make the poison, but there's not as much levers that you can pull to continue running with an Achilles tendinopathy as much as you may have different levers that you could pull with like a hip flexor, a hamstring, or a knee.
Mm. With these Achilles rupture, quad patellar ruptures, there's time frames, like the healing time frames or the healing process, because sometimes they're just not getting that pain signal. Like usually with the tendinopathy, we can listen to pain and be like, okay, we've done a little bit too much. But there's people that are like a few months out. I had a quad tendon guy like a few months out, which is like not safe to be getting back to dynamic stuff, but feeling no pain, function is perfectly fine. And he's like wants to push things. So I'm like, probably not smart. Um, how much are you like when you're rehabbing someone in that like long term coming back from a rupture, you're always paying attention to these time frames just to be cautious?
Yeah, I would say especially in the case of like surgical repair or rupture, yeah, 100%, because you don't know what happened to the nerves surrounding the area. Like it just could be completely like deaf to mechanical reception of like, yeah, what is actually happening there, and it just feels great. Yeah, it's because it's probably numb. Like, yeah, of course it feels good, but we don't know or have like our finger on the pulse of like what's really getting into that tendon because it's not giving us the feedback that would be in a normal person. That I think you do have to be a little bit more cautious. And in those kind of cases, it depends on who you're working with, but like it's kind of like what risk do you want to take? How meaningful is that risk that you're trying to take? If this is the difference between you making it into like a military selection, and this is your one shot at it, and you're not going to ever do it again. Okay, maybe we're willing to accept the risk that this could re-rupture during that training process or during what it takes to actually go through the test itself, because it's just you're rolling the dice. And as long as you've agreed to that and we know that that is the dice that you're choosing to roll, that's 100% on the person of how they want to guide their health and how they want to live their life. I'm not going to interrupt that. I just have to educate them that like it is a risk. But for the most part, with people that are just dealing with this and they just want to return to full capacity and function again, I'm going to be a lot more conservative, and I'm going to try to educate them and lean them towards like, hey, we don't need to get ahead of the curve. We don't need to like have a miraculous outcome with this where it's like you're doing things that the surgeon said you wouldn't be able to do way sooner. Because at the end of the day, like, what do you really want to do? And what happens if this does, happen again? Do you really want to go through this whole process again? And I'm not trying to like make you afraid of it. It's just that what risks are acceptable to you. And I think that if we really evaluated that of what you really truly want out of life and what you want a year from now and 2 years from now, that you may just slow down on the progression. It's not that any of the things that you want to be able to do or get back to doing are inherently bad or dangerous or will never be on the table. It's just like, let's just keep riding this course, man. Things are going really well. Like you're jacked. Your cardiovascular training is going up a ton. Like we're moving closer to those visible abs. Like you're sleeping way better than you ever have because we're actually thinking about it now. You actually like thought about macros for the first time. Like when's the last, in the last 2 decades of your life, you've not gotten very good protein consumption, and now you are. Like we're doing a lot of good things here, dude. Like we don't need to get back to jumping just because it sounds sexy or it looks cool.
Yeah, yeah. That Peter Malliera's story, it wasn't on my podcast. I think it was on one he did soon after. I
Mm,
listened, yeah. But I thought it was the healthy leg doing like a pogo hop. I think that's what it was. Yeah, and but he said
mm,
he scanned it right before, I guess with ultrasound, and it looked pretty healthy, and then it ended up rupturing, and the guy was like, ah, whatever. He was really cool about it, but yeah, I
yeah,
think that's what the story was because I don't think he said it on mine. I heard it afterwards, and I was like, oh my god. Um, but
yeah.
even though, yeah, go ahead.
No, man, he gave a presentation to like the first principles of movement thing, and man, I don't want to be wrong because it very well could be a pogo hop, but I swear on that call in particular, he said it was like an overcoming ISO, like one of the
Oh, okay.
safest. Like,
Yeah,
and that was
yeah.
what was like even more shocking about it. It was you're literally doing an isometric, pushing just as hard as you feel comfortable going, which is like the most absurd thing. Even the Alfredson case that has tendon pain, and he's trying to rupture his Achilles, which kind of was part of the history of how we know load is good for Achilles or good for just tendons in general was his story. But it's like I could be wrong. It very well could have been a pogo hop. I just remember listening to it, feeling like even Peter himself was like, "This is such an anomaly that it was so far off base, and yet it happened." Anyways,
Yeah.
crazy
Yeah.
dude.
And then he said he went white or his assistant went white in the face or something like that.
Yeah,
I did
yeah,
try to get on that call and then I couldn't log in, so I had to watch the recording afterwards. But um the oh man, what was I gonna say? Oh, someone reached out to me. I think they had tore their quad tendon and they were like 4 or 5 months into rehab and they had a quad ISO test and they re-ruptured the quad tendon in that test, and it was like they were suspecting that maybe they messed up the surgery in the first place. But yeah, I mean those things do happen. You'd think they wouldn't, but they
yeah.
definitely do.
They do. There's anomalies out there, and again, like just embracing some level of uncertainty, both from flare-ups can potentially happen. Embracing some level of uncertainty, even with like the Berlin Protocol, it's great. I think it's a marvelous thing. I'm really happy that a lot of clinicians are talking about it because I do think it's important to understand how these things work and the tendon does need to reach these levels of strain. But you very well may work with someone that just for whatever reason it's not working. But what are you going to do? Are you just going to keep banging your head against your keyboard and be frustrated at like I'm doing the thing that that I'm supposed to do? Well, there's something going on that for whatever reason this person is just, and who knows, like they could be lying, they could be telling you that something is done and it's not, but like you got to find a different way. And so I think just being a little bit cognitively flexible in some of these things, even if you have the best thing, and embracing the uncertainty that like, dude, you can do all the things right and things might not go right just because you're doing all the things right. That's okay. That we can embrace that and still make progress in other areas and have a meaningful, rehab process all the same.
I think a lot of the you probably see this too with the phone calls. I just do like phone consults with people and then I will send them an email and do just follow up, make sure they're doing fine. But um, a lot of these people that are trying to rehab themselves, and there's always probably like 90% of the time this elephant in the room that they're just completely missing. And it's like, I can help them. When you have a conversation, you can kind of expose it. So I'm thinking of that like Berlin thing. If someone's like running through it and they're like 2, 3 times a week, it's supposed to be magic for my Achilles. It's like probably within like a 10, 15 minute conversation, you could just find something common sense that they're missing that you're like, okay, this is probably what you're not doing right. Or like maybe it's too, maybe the common sense there is it's just too much load. Let's just do a little bit less. Maybe you just can't tolerate this.
Bingo. Man, and that's why I said that. That's why, man, going back to this, I think sometimes when we get so pointed at fixing the pain, we don't have these conversations of like, what have you been doing? Like, what does your programming look like? What do you think is actually going to help? Because yeah, like 90% of the time they're just doing something like the elephant in the room that's a glaring error, well intentioned, but probably not what's going to actually help them. And just by adjusting that programming, like you can make this very simple for people. Jared Powell, who's a shoulder expert, was talking about like shoulder research and even in tendon stuff. Like you give a person one exercise, just one for tendon pain, that errs on the side of a little bit more pain, like 4 or 5 out of 10 pain, and they just do that one thing either every day or every other day, so either every day of the week or 3 times a week, and it is just as good at treating tendon pain as all of the typical physiotherapy care that could be provided for this person. So it's like sometimes just doing less is more, that you get this addition by subtraction, taking away all the dumb stuff and just taking away all of the minutia of every mobility drill under the sun and every treatment modality and just give them one solid thing to hang on to that they've been doing a little bit out of pocket, and good things can happen there too. So it doesn't need to be all that complicated. Yeah.
Yeah, I don't know if it was you that I saw recently. I think it was you about someone that has been rehabbing for so long and doing so much work to tell them like maybe you can just take a little break for a bit.
Yeah, 100%. I have a number of clients that fall into that. They just try to do everything. They think they're pulling every possible lever in every possible category, and all they're doing is, and eventually you'll talk to someone. Everyone's come across this person that's just has a very flexible life for whatever reason, a lot of resource and time, and they'll spend, gosh, 2, 3 hours a day on their rehab stuff, their mobility, their everything. And it's like, have you ever just thought about caring a little bit less? That's a line from Derek Miles. Like, have you ever just thought about caring less? Because if you did care a little bit less and stopped like poking it, all the time trying to make it better, it may just happen on its own. I remember I had hurt my back pretty bad. Sprinting, actually, just doing a lot with running. When I was fresh out of PT school, I had moved. I was working at a strongman gym in Montana as a physical therapist, and for whatever reason, that sprinting had messed up my back, and I was trying to do everything. I was doing every possible little movement and thing I could think of, and I remember the one of the other therapists there was just like, "Dude, stop dicking with it. Just let it be for a minute. Just don't even mess with it. Don't try to fix it. Just go about your day." And how about you just try nothing and just do only movements in the gym that like don't even make you think about it, just machines, everything that feel good, and just forget about it for a couple days. And it was just that alone got me like 50% of the way better. So at that one instance, now I don't think that's always the answer for everybody, but sometimes yes, that is the lever that needs to be pulled is the addition by subtraction.
That's I've hurt my back a few times. Um Probably deadlifting and squatting. And I guess I've never cared too much about those activities, so I would just stop. I would just let it give it a break for like a month and let my back recover. And in the meantime, I'm just working on my arms and my shoulders, and I would get everything else like hypertrophy in the upper body. So I'm training upper body 5 days a week or like doing machines and stuff. But yeah, my rehab for low back personally, my personal anecdote is like do nothing and just let it recover. And then for like the knee or for the Achilles is like a very active approach. But
Hmm.
it's just for me of like I need to use my knees, you know? And it's worked for me. But yeah, the whole just like giving the thing a break because that's what will come out of the conversation. Is you have a conversation. It's like any logical person would say, "You've been doing this for 6 months. We probably should do something different." You
Hmm.
know, probably not working.
For sure. Yeah. And it could just be a matter of like they are in that rehab purgatory of like, I just want to go back to dynamic load. I think, man, it's mind boggling how many strength and conditioning and performance coaches that work at even high levels still promote the idea that doing fast dynamic activities is what trains a tendon and that it makes it stiff. And it's like, probably not. I mean, we know that like when you do really dynamic stuff, that the tendon still does go through a strain. It still does elongate and store kinetic energy and release it. That does happen. It's just not to a level for enough time that it gives a lot of those mechanoreceptors the ability to really respond well, or potentially it's overloading that strain repetitively that like now you've made the same way that in a bone stress injury, that tendon does become a little bit deaf to load, so to speak, that like it's not able to continue to adapt to just more. Like you've talked about this with some of your previous guests just recently, Gaspar, I
Yeah,
believe,
yeah,
Espro that was just on, who talked about like the studies between doing every day, and that you reach a certain point where it's like, yeah, at a certain threshold that just more is not going to just be better. We reach kind of a minimum effective dose where it's like that's it. And I think that happens too, but it's just crazy to me that people still are under this guy. They go look on YouTube and see these high performance coaches that have all these followers talk about that, like, oh yeah, you got to make your tendons stiff by doing these like plyos and this fast stuff. This is where it's at. And so they think that what you're giving them, these, maybe it's ISO, maybe it's Berlin protocol, maybe it's just some heavy slow resistance, is the rehabby stuff that's not really doing the stuff in the tendon I want it to do, that I need to do this fast dynamic stuff. So they just may be pulling that lever too often, that every time they just get over the hump of feeling a little bit better, it's dynamic lever time. Let's go. And it's like, do you realize that that is the very thing that's keeping you in rehab purgatory? We just need a little bit smoother progression out of this hole. And I think, yeah, it's just there's a lot of narratives that continue to be perpetuated, even like the deep range of motion stuff across the board, like an assertional Achilles. There's nuance there. Yeah, going through a full range of motion to full dorsiflexion is not going to be great for that. A patellar pull is not going to enjoy going through deep knee bend excursion over and over again. That's not how you are going to treat that successfully. Even full range of motion for a mid portion Achilles, sometimes if there's plantaris involvement and you get some sliding happening, that also isn't going to be an option. So like there's so much nuance here, and people just want to put out that like look at me, I have the answer, and just do this, and then people follow it errantly. And sometimes if they just stop doing some of that nonsense, they'd be a lot better off. But anyways, rambling.
Yeah, dude, I think one of the hardest things is conflating pain with like anything mechanical, you know? It'll be like, this is good for tendon stiffness. So they're like, oh, I need to do this for pain. And it's like, no,
Yep.
pain is the most complex thing that there's no thing that you can chase after to say this is going to reliably decrease your pain. But um, yeah, it's always it can never get have the conversation over text. It's like it has to happen through explanation. But yeah, the a lot of the rhetoric, I was reminded of Louis Simmons back in the day. I think it was Louis saying, they would do those fast, uh, like banded tricep pushdowns, and he's like, "This is for the tendon. This is for
Mhm.
tendon strength or something like that." And it was like, "What? How is that for?" Because for them, they're not doing like their power. They're not doing sprinting and all those. So I'm like, maybe this is their replacement of that stuff. But I would have people ask me like, "How is this the case?" And I'm just like, "I don't know, but I don't think it's changing anything mechanical. I think maybe it's just making your tendons feel good." Because
Yeah.
you're doing something a little bit different and maybe getting blood flow or something like that. Maybe it's just making you feel good, but maybe it's doing nothing at all to the tendon.
Yeah.
You just feel good. But it's like conflating pain symptoms or feeling good with something is happening within the tendon is like, well, they're not the same.
Sure. Well, yeah, I mean, in the Louis case, it's like, doing some lower load, higher rep stuff for your tricep versus benching 550 or 600 in an equipped bench probably does feel a hell of a lot better for your tendon on the elbow, the same way that, sending it on a 1 foot approach dunk probably is going to feel a little less great than doing some like, you know, uh, low box step up. Yeah, but it's not body weight low box step up or, a knees over toes split squat isn't necessarily training the tendon the way that you think it is. It just feels a hell of a lot better than the dumb stuff you were doing before.
Hmm. Yeah.
Yeah.
All right.
Anyways.
Q, you said you're doing stuff online right now. What's next for you? Or are you
Yeah,
gonna keep
brother.
doing this?
That is the current predicament. There's a couple of really exciting options in the pipeline that I would be excited to do, but I really love treating people this way too. So I'm kind of at a crossroads right now, not exactly sure which way I'm gonna fall at this exact moment. But yeah, I treat folks online, do a lot of remote rehab and programming for people that involves full comprehensive training programs, not just, so if you came to me with a knee pain, it's not just a knee program, it's a full body training session. We're just baking in the rehab to that and whatever you want to do, if it's, high rocks, if it's CrossFit, if it's endurance running, marathon runners, I've got a couple of those, couple of trail runners on my roster now. So anything you want to do, we're going to try to do the best we can, or I'm going to refer you to the people who I think would do a better job than I would. But yeah.
Hmm. All right, tell people where to find you.
And primarily, Instagram is the best place. Probably, it's kind of the media platform I use the most often. I have a website as well. It's just Find Physio, findphysiotherapy.com, I believe is what it is that you could find me. And then on Instagram is probably the best place. Coach_Q_physio, Coach Q Physio. There's a link in my bio for people to fill out a questionnaire and give me an idea of what we're up against and what we're dealing with, and see if it's a good fit to work with me with rehab. But that's probably the best place. The DMs at this point, man, there's literally hundreds and hundreds of Instagram DMs that have just buried in the ether. Don't DM me, please. It's gonna just get buried, and I'm really sorry for anyone who has and I haven't responded. It's too much. I can't. If it's a questionnaire that comes through on my desktop, I'm gonna see it. If it's a DM on my cell phone, it's just probably not gonna be seen.
Yeah, I try to answer mine, but it will take hours and yeah, often is not even worth it because not very serious people in the DMs. What are you speaking soon at any event? I saw you were speaking recently. Are you?
Yeah, yeah, there's a few coming up. So I will be speaking next would be Exos, speaking at Exos with the First Principles of Movement Group. So if you'd like to join us there, we're doing like a 2 day, I guess it's 2.5 day, like full clinical course for trainers, for coaches, for chiropractors and PTs of how to integrate exercise and a lot of the stuff that we talked about today. Like these types of conversations we'll have there at Exos in December. In January, I'll be speaking at Duke University with their sports rehab team and going over some speed and change of direction type stuff with them. And then I'll be speaking at Eric Maida's the Elite Football Rehab Conference in Minneapolis or Indianapolis, excuse me. That'll happen in February. So a couple of different speaking engagements coming up.
Perfect. All right, man. Thanks for we've the time has went way over, but thanks for coming on.
Yeah, hope it was enjoyable. Appreciate you having me.